All right, common bone tumors. So a little bit about who I am. Local, I went to Douglas High School, undergrad at UNR, med school at the University of Nevada School of Medicine. And then I did my orthopedic surgery residency at Loma Linda University in Loma Linda, California, followed by a sports medicine and shoulder fellowship at Hoag Orthopedic Institute, Irvine, California. So no disclosures on my end. We'll jump right into it. So just a couple kind of terms that usually help with talks like these is understanding lytic lesions, which is essentially it's the tumor or mass of some sort has removed bone. Typically we think of lytic as aggressive. However, that's not always the case. And we also think of it as bad, which isn't always the case. This example, this is a giant cell tumor, which can be aggressive, but it's not cancerous in any way. The other type of lesions we can get are blastic, which are bone forming. These will be more things like Paget's disease or typically METs. Certain breast cancers can be blastic, or prostate cancer would be more of a blastic type tumor as well. And again, kind of help with understanding X-ray reads. And for the orthopedic side of it, it's important knowing where on the bone it is. So just as a quick reminder, the epiphysis is the tip of the bone. The epiphyseal plate or growth plate, physis, where the growth occurs from in the pediatric population. Metaphysis is the flare leading into the epiphysis, and then diaphysis is kind of the straight middle portion of the long bone. So we'll start with the kids. I feel like, especially in this population, in the family medicine world, a lot of times there's going to be pediatric tumors that are found pretty incidentally. This, at least for us in residency, occurred pretty regularly for both malignant and benign tumors. It tends to be typically seen after they injure the area for another reason, get an X-ray, and then a tumor's found. And usually the question is, what is it? And what do you do with it after that? So most of the common bone tumors are going to be benign. So we'll go through some of these first, and then we'll kind of touch on the bad ones towards the end. Those are going to be a little more rare, but usually easier to identify. So the first one,
Dr. Shields, I apologize for interrupting. We do have an attendee that joined. Dr. Wadia, would you mind introducing yourself to our hub team today?
Hi, I'm Gurjeet Wadia. I'm a pediatrician in Reno. Thank you.
All right. Thank you, Dr. Wadia. And Dr. Shields, please go ahead and proceed.
Oh, perfect. Well, then for pediatrics, this talk will be pretty good then. As we were saying, most of the common bone tumors that you find tend to end up being incidental findings. A kid hurts their knee, you get an X-ray, and you see a lesion. So it's kind of, what do you do with it from here? So the first one we will go over is unicameral bone cysts, also known as a UBC. So it's a benign fluid-filled lesion. It's typically found in the metaphysis, mostly proximal humerus. A lot of times kids never feel it. Again, they'll find it with an injury, or it'll present with a pathologic fracture. The X-rays will show a central lytic lesion. It's well demarcated in the metaphyseal region and has some expansion. So here's what we mean by that. So this is a UBC within the proximal femur. They occur close to the growth plates, and they'll grow with the kids. Typically, once the person's reached maturity, done growing, the cysts stop growing as well. And a small portion of those can heal in. They are these lytic lesions, which means the bone's taken away by the tumor. When it says expansile, it starts in the center and sort of expands out towards the cortical edges, and it can actually thin the cortices pretty significantly, and that's when the pathologic fracture happens. These ones usually aren't painful or symptomatic until there is a pathologic fracture. From our end, they're a little bit hard to treat. There's a good portion of them, especially in the proximal humerus, that if you just treat it closed, they'll fill in and never have any issues. The fracture can also heal around the cyst, with the cyst still being present, and then it's a discussion of whether to try and treat the cyst. But without a big surgery with bone grafting, it doesn't really, all the other treatments are kind of plus minus on whether they'll work. Next one along the same line is an aneurysmal bone cyst, also known as an ABC. Another benign lesion. It's reactive and commonly occurs in the femur or tibia, but in a similar position in the metaphysis near the epiphyseal region. Same type of situation. It may keep growing while the patient's growing, and then once it stops, it'll be done. The x-rays show an eccentric lytic lesion. So kind of a subtle difference between the UBC and the ABC is the UBC will kind of start more towards the periphery, where the UBCs will be pretty central and expand out. It's pretty septated, and the septae are filled with blood. So this is more what we're talking about with that expansile septated type look, where there's multiple caverns. It's really thinning the edge. And a similar type treatment algorithm goes with this compared to the UBC. There may be pathologic fractures. The aneurysmal bone cyst may pop up in weird places as well, such as the calcaneus, and you can get them in some flat bones as well. Again, this is benign, but once there's a pathologic fracture, a lot of times it does have to be treated, especially in a weight-bearing bone. Next one, non-ossifying fibroma. This is probably the one you guys, I would imagine, would see the most. You know, it's the classic story. Kid has a knee injury, x-ray done, and there's a lytic lesion, usually near the metaphyseal region. Typically along a tendinous insertion. So a lot of times it's the medial head of the gastroc is where we'll see it at. And again, a lot of times it happens around the knee. So distal femur, proximal tibia, and around the distal tibia as well. And then keeping up with the abbreviations, this one gets one also, the NOF. So this is a good picture of one. This is a nice picture that makes it clear, but kind of this bubble-like appearance along the metaphysis, again, right along the cortical edge. It's typically, again, near tendinous insertion, and it's just a fibrous malformation of the bone. These ones are typically not painful in any way. And again, it's a purely incidental finding on x-ray. The hard part is it is a lytic lesion, so sometimes it can be a little scary when you're looking at it, especially since it's near the edge of the bone. Very rarely do these require any treatment for them. So chondroblastoma, this, you know, I know this is common bone tumors, and this one's talked about being pretty rare overall. However, it is another one that it seemed like from our tumor clinic was referred over, you know, knee injury, pediatrician, family doc got an x-ray, and there's this lytic lesion before it ever actually became painful. It's typically described as pain at the tumor site, and it's hard to say because, well, you know, some kid hurt their knee and that's when it was noticed and painful, or are they actually hurting from this tumor? This is a benign lesion. However, it can be a little bit aggressive in some ways, and it is lytic and can be expansile. So this one is the true epiphyseal lesion in a kid with open physes. So down on that medial condyle of the femur, you can see that lytic lesion. Growth plates are open. It can expand into the metaphysis as well. So you can see bigger versions of these. But the one sort of in this x-ray is typically the one that, again, you'll find with an incidental type finding. It's pretty localized right in the epiphysis. And these ones often do require treatment because they will become expansile. So lots of times there's surgery with bone grafting involved for these. Osteochondroma, another big one that's typically seen probably in the primary care field. It can be a singular lesion, or it can be related to genetic disorder, multiple hereditary exostoses. So that's when you have several of them. Most of them are around the knee. It is the most common benign tumor. usually noticed first in adolescence because it is associated with the growth rate. So when you get these big growth spurts, the lesion gets bigger and they become more symptomatic. Again, around the physis, sort of near tendon insertions. There is a rare crossover where it can convert to chondrosarcoma. This rarely happens in the pediatric or adolescent population, but if it can happen when patients have them later in life. If you're ever in doubt on these, an MRI can be ordered because the cartilage cap and the thickness of the cartilage cap around it is what predicts whether or not it'll be somewhat dangerous. So we talk about a 2 centimeter cartilage cap, which that's a pretty big size of just the cartilage, not even the bone around it. If they are symptomatic, they can be surgically removed as well. If not, then no problem leaving them. And this is a pretty typical picture of a large one. Again, it doesn't matter how big the bony structure is for whether it will convert to chondrosarcoma, but how big the cartilage is around that cap. So if you see this x-ray and there's this big piece, but there's also a big soft tissue portion overlying it, that's when you would be like, okay, well, maybe we need to get an MRI, see how big that is, and send it out. Otherwise, most of these, it's going to be just whether they're symptomatic or not. Osteoid Osteoma. This is another one that will be typically found in the primary care office. Most of the time, you can't even see them on the x-rays themselves. You'll have usually somewhat of an active kid, a very focal regional pain along the hip, the ankle, around the knee, horrible at night. The pain is significantly increased at night. And then when they take NSAIDs, it's completely relieved for the time that the NSAIDs are working. Again, small lesions, less than 1.5 centimeters, but even more often than not, it will be smaller than that, to where there's no significant radiographic findings. It tends to be sort of on a bit of a hunch that it's checking all these boxes: the horrible pain at night, the NSAIDs helping decrease the pain dramatically. So the big finding on the imaging is there will be a central nidus, and oftentimes there needs to be a thin cut CT scan of the area to see it, and it is often treated with radiofrequency ablation. This one can also occur in the spine and cause a postural scoliosis that's also painful. Again, if it's accessible, treated easily with radiofrequency ablation. So here's a good picture of one of them, right there along the trochlea. You can see that lesion with the central bone nidus in it. This one would be a good one to treat with radiofrequency ablation. It's easily accessible. And again, it's hard to pick these up on radiographs. This is actually a pretty big one. The thin cut CT scans are usually what's required. So for the older population, we talk about bone tumors in the pediatric population. The bulk of them are benign. There will be, we'll get to some of the more aggressive cancerous ones later, but the vast majority of the adults you're going to see with a bone lesion, you have to think metastatic disease. And it's going to be metastatic disease until proven otherwise, essentially, in this population. So anyone over 40 that has a bone lesion should have a metastatic workup and metastatic disease worked out or ruled out. Sorry. So evaluation usually starts with plain radiographs. If you are waiting for referral to a specialist or anyone like that, MRI with and without contrast is also a great next step. Staging as well with a CT, chest, abdomen, and pelvis will get you ahead of the game as well when it does get referred to the specialist. Continuing on this, the imaging workup we talked about, labs are pretty essential: ESR, CRP, TSH, CMP, CBC, and then I forgot to put it on the slide, but in men, PSA is also a huge one to add on. So typically a biopsy is recommended as well. And then in general, anytime a biopsy is going to be performed, we typically try to get it to the surgeon that's going to do any definitive treatment for it as well. For metastatic disease, it can be performed at the time of surgery as well. So where do the bony mets typically come from? The good old BLT with a side of kosher pickle is how I remembered it. And that's how I got through any tests in orthopedic residency or PEM questions, was remembering this one. So the BLT, breast, lung, thyroid, and then the kosher pickle adds on the kidney and the prostate for this. Most of these metastatic lesions will be lytic, but as we talked about earlier, there are a few of the blastic forming ones. Breast can have a blastic component, and prostate will typically be a blastic bone forming type tumor as well. Along that line, multiple myeloma will be another major one for the adult population. So proliferative tumor of plasma cells, typically presenting with localized pain. Most often we would see these ones with a pathologic fracture by the time it got to us. The diagnosis is made with a bone marrow biopsy showing a large percentage of the plasma cells. And then if there is confirmation of the multiple myeloma, a PET scan is recommended because a secondary lesion is going to be found in about a third of patients. So this is a good picture of the multiple myeloma, just a totally lytic lesion along the center of the diaphysis of most bones and starting to wear out into the cortex. And that's where the pathologic fractures come in. And then we'll kind of go through some of the bad ones quickly. You don't see these too often, but it's ones that everybody should be relatively aware of, because if you see something scary, you got to get it out to someone. And that includes me. If I see something scary, I get it to a much smarter orthopedic surgeon than myself. So Osteosarcoma, again, Dr. Scott, you were talking about your patient population. This is probably the one you're going to see the bad ones of more often than not. So malignant aggressive tumors, they're often found in the femur, typically children and young adults with rapidly progressing pain and swelling. The reason for that is there tends to be a soft tissue mass component over the top of the bony component as well. Biopsy is the standard for diagnosis. This is done well in advance of any surgery. It's typically you see one of these lesions, we get it to an orthopedic oncologist, and biopsy is done almost before anything else. And then a chest CT is really the only metastatic workup that's done, unless there's pain anywhere else. And then a bone scan for any other bone lesions. It typically only mets to bones and the lungs, however. So this is a good example of one. This is here in the tibia. It has sort of a bone forming but destructive type process to it. So it's not purely lytic like that giant cell we showed at the beginning for a definition of a lytic lesion. It still keeps some of the bony borders. Problem is it's destroying bone faster than it's laying down. And then oftentimes in the x-rays, if it's breached the cortex, you'll also see a soft tissue shadow around it. Anything that looks like it's eaten away the bone, especially through the cortex, is one that, you know, I personally am going to get over to an orthopedic oncologist sooner rather than later. Ewing sarcoma. This is more in that pediatric population. However, I have seen it in, you know, as the books say, up to people under 25. There's a couple in that college population that I've seen with it during residency. So this is a small cell bone tumor, typically in the diaphysis. It gives this moth-eaten appearance with kind of bites out of the diaphysis and along the cortex as well. You can kind of see in this x-ray, the distal metaphysis looks like normal bone, and then you get this sort of blurry eaten out picture kind of along the diaphysis. Again, this is another one that looks somewhat destructive, meets the age population, get it over to an orthopedic oncologist pretty quickly. Chondrosarcoma. So this, we went through probably the two scary ones for kids between the osteosarcoma and the Ewing sarcoma. this is the scary one for adults where it's not a multiple myeloma or a metastatic injury. This is a primary bone tumor of chondrocytes, and it's usually over 40 years old with a painful increasing mass. These ones can also be in the pelvis too, and they'll go unnoticed for a while because they'll be in the pelvis. There's more space for it to expand before something else is going on and it's noticed. These ones typically are treated with radiation and surgery. So all these other metastatic ones, the patients might be on chemotherapy. This is a one where chemotherapeutic agents don't work, so you'll have your patients will be on radiation typically instead with these. That's kind of it for the rundown on the common bone tumors, and again, a couple scary ones at the end. I think the big takeaway with any of this is you don't really want to miss anything. There's never anything wrong with, even if you think it's benign, to say, hey, let's get this over to an orthopedic surgeon that's probably seen, a few of these more, at least has looked through them and said, okay, yeah, that one's pretty benign looking and we'll watch it, versus no, let's get this over to Davis or an academic center for a better look. And I even personally have probably a pretty low threshold to get it over to someone else, because there are so many times, again, they're rare, but when you see them in an orthopedic tumor office so many times, there are those unusual presentations to some of these that it's just better to have a second look at, and it never hurts. So that being said, I left my contact info up here. Feel free to email me, call, text anytime with bone tumor questions, or more preferably sports medicine questions, but I can help with the tumor ones anytime as well.
Thank you, Dr. Shields. At this time, does any of our attendees out there have any questions or comments they'd like to make regarding the presentation?
I have a couple questions.
Go for it, Dr. Scott.
So, Dr. Shields, what's a time frame I need to have these get in? A situation would be, gee, I do an x-ray in April, my patient's primary care and all their insurance is in Las Vegas, they want to wait till June and have it seen and be seen down there. I mean, if I see something, well, let's just say it's like might be in the more benign category, how soon should I say? I mean, do I say, hey, parents, we really need to do this now? It's okay to wait a month or two?
I think anytime, especially in the more benign looking category, a month or two is totally reasonable. So if it's happening at the end of the school year, they want to get worked up down there, that's fine as well. Just getting the ball rolling would probably be ideal, so they can just get an appointment for right when they get back home.
And on those osteochondromas, if we want to get an MRI on it, is that also with and without, or just without?
That can be done without,
Okay.
just because we're totally just evaluating the cartilage cap on it and the size of it, and it's more of a numbers game. Yeah, your population would be right in that range because they've been done growing, most of them, for right around 4 years. If the thing's still growing on them, or it does have a large cartilage cap, that would be the one group that can be concerned, especially in the ones that have multiple. The multiple hereditary osteosis group has the higher conversion rate. Again, it's really rare, but I mean, it depends how long you're kind of right in that age population, but through your practice, it wouldn't surprise me if you saw one that may convert at some point. The good news is it's a low-grade sarcoma. It's treated pretty easily with resection, almost the same as if you were just taking out the osteochondroma anyway, but it adds a little bit of urgency to it. So.
Yeah, I had a young man come in not too long ago and show me that he had a golf ball growing on the inside of his knee.
Yeah.
And it was pretty big.
Yeah, and so if his physes are closed and he's still getting some of that noticeable growth, that'd be a good one to MRI.
Gotcha. Okay. I don't want to take up all the questions if anyone else has any, but I still have a couple more.
Go for it, Dr. Scott.
Does somebody do radio frequency ablation in Reno for the osteoid osteomas?
I'd have to look into that. And I know there's people that do radio frequency ablation for certain things, but I'd have to look if there's anybody that does for the osteoid osteomas in particular. That's a good question.
I just had a patient with that, but he's going off to somewhere in Sacramento, so
Okay,
I'll probably have it done down there.
perfect.
And then the last one I had a question about, this was a patient we had a long time ago, and I can't remember the exact diagnosis, but one of the more benign lytic lesions by her knee, but it was so humongous, they decided to fill it with cement.
So that would probably be the giant cell. I didn't put a specific slide on that, but I do have that picture to kind of describe the lytic lesions. So it does look kind of scary because it is just this massive lytic area here. It is benign. There's a low, they call it benign aggressive because there's a low chance of some pulmonary mets from it. So the other workup you can get when you see this is a chest x-ray to see if there are any larger ones, but I wouldn't jump straight to a CT scan on that for the radiation. But this one will be kind of the metaphyseal epiphyseal region, large lytic lesion like that, that's shown, most common around the knee as well. And then that is the treatment, is going in, opening up the lesion, you curette it out, and then the bone cement is what we call the adjuvant. So you add something on to try and kill the tumor, whether it's heat, you can do liquid nitrogen into it and then bone graft it, or you can fill it with cement because the heat from the cement should, in theory, kill the lining of it as well. So there might be a couple different treatments you see for these, anywhere from the bone cement to bone grafting, and with the adjuvant that's added on as well.
Gotcha.
Richard Obringer, do you have a question today?
I just wanted to ask, who is usually involved in the decision-making process and performance of amputations? And then, might be a whole different topic, but, referral for prosthetics.
Yeah, the amputation decision, it's very much the surgeon. And well, the surgeon and the family, but a lot of it has to do with where the lesion is located, and the other structures it's around. If to get it out, you have to take out major nerves, blood vessels that are going to limit function. A lot of times amputation's a better option. The bone salvage and limb salvage has grown significantly within the tumor world. So there are a lot of new techniques to try and transport the healthy bone down once you've rid of the cancer and things like that. I would say amputation is much lower on the kind of primary surgery side, and usually reserved for you've tried a few different things and it just hasn't worked out. Including we're getting better at putting in, or I shouldn't say we, the tumor orthopedic surgeons are getting better at putting in what are called endoprostheses, where it's a whole distal femur can be resected and there's a joint, or they're also getting very good at intraoperatively dissecting just out of clear margins and creating sort of bone grafting techniques once you've cleared the tumor bed as well. So there's a lot more limb salvage going on. And I would say amputation is reserved for those ones where other vital structures are already kind of out of the way and the function's not going to be very good, or the limb sparing stuff has failed.
And I guess as a follow-up question to that, do you sometimes work hand in hand with the oncologist in making that decision? And then would you, in presenting the patient their options when it looks like the amputation might be a more favorable option, to at least refer them to a limb salvage specialist to weigh those options?
Yes, absolutely. The decision in that the oncologists typically aren't really guiding that treatment, again, because it's along the structural side and the surgical side of it. the biggest part the oncologists play is helping kind of look at the, oftentimes there's pre-surgical chemotherapy to try and reduce the size of tumors and increase the chances of limb salvage. That, so they're involved usually with that and how the treatment's going, assessing the overall size on these tumor boards, but typically not necessarily in the actual limb salvage conversation. And then I would say most tumor specialist orthopedic surgeons have moved towards the limb salvage line of things. If there's ever any question on that and somebody wants a second opinion, I know several that are, bill themselves as limb salvage type people, but that's definitely the direction any new training's kind of gone, is towards trying to do all the limb salvage as well.
Thank you.
Yeah.